Good morning, everybody. This is the cost versus effectiveness debate. Thank you all for coming, and I'm glad to see that the seating problems have been addressed this morning. I'm Bevan Yu. I'm delighted to help co-chair this. I want to introduce Mr. Nigel Beasley, who is seated to the far left here, who is my co-chair as well. Just to give you some understanding, Nigel is a consultant ENT surgeon, and he is the Deputy Medical Director at Nottingham University Hospital's NHS Trust. He is trained in some of the most prestigious institutions in North America and Europe, including Guy's Hospital, Liverpool, Oxford, and Toronto, Canada. And he returned to Nottingham in 2002. Nigel has a particular role with the National Health Service in Great Britain for innovation and improvement, and he was the Deputy Medical Director at Nottingham University Hospital. He's taken on particular responsibility for the appraisal of technology revalidation and clinical effectiveness. I want to introduce our four very distinguished panelists as well. The first here is David Terrace. David is the Perupsky Distinguished Professor and Chair of the Department of Otolaryngology at Georgia Regents University, and he is the Surgical Director of the Georgia Regents University's Thyroid Center. I think all of you know David has been a pioneer in robotic and minimally invasive thyroid surgery, and he has a very busy clinical practice limited to thyroid and parathyroid surgery now. He has developed a new robotic facelift thyroidectomy that results in a scarless surgery, and recently he has become the chair of the Otolaryngology Advisory Council of the American College of Surgeons. Next to him is Dr. Schuler. I think all of you know Dr. Schuler, a legend in our field. He currently serves as the Vice President of the Ohio State University Medical Center Expansion and Outreach, and he is the CEO Emeritus of the Arthur James Cancer Hospital and the Research Institute. He is a former professor and chair of the Department of Otolaryngology. He's had numerous leadership positions at the Ohio State University in expanding that university's footprint. He's a member of our collegium. Actually, Dr. Schuler's very thoughtful editorial in JAMA Otolaryngology about a year and a half ago was the genesis for this panel. Greg Weinstein is next. I think all of you know Greg as well. Dr. Weinstein is Vice Chair and Professor of Otorhinolaryngology at the University of Pennsylvania. He's the Director of the Head and Neck Surgery Division as well. He's the author of over 120 peer-reviewed manuscripts, and he obviously has been a pioneer in the development of TORS, transoral robotic surgery, TORS surgery, here in the U.S. and internationally. He's a co-founder of the first world research program in human TORS, and he has probably trained hundreds of American and international head and neck surgeons in this technique. Dr. Renee Leemans is to Greg's left. Dr. Leemans is chair of the Department of Otolaryngology and Head and Neck Surgery at the New University Medical Center in Amsterdam. He's had that position since 2002. He's the co-director of the Cancer Center in Amsterdam and the director of the Otolaryngology Residency Program. He is a member of the steering committee and chair of the surgery subcommittee for the EORTC Head and Neck Cooperative Group. That's the European Oncology Research and Treatment Cooperative. I forgot what the C stands for. Thank you. He is also a member of the collegium, and I think with 270 papers plus, maybe over 300 by now, he is well known for his very thoughtful and reasoned approach to clinical investigation. I have no financial disclosures to make. I think just as an introduction, what I hope to do today is just to set up the debate. I think all of the people in this audience are now aware of the evidence-based movement. This is a worldwide movement, and essentially what it says is that treatment that we select must be justified by clinical evidence of effectiveness. This is for our patients. Our patients care about it greatly. Insurers and third-party payers increasingly pay attention to this, and our colleagues also pay attention because we all offer competing versions of treatment for similar diseases. All of you are familiar with this chart. This is a well-established hierarchy of clinical research and effectiveness. All of you know about recommendations A, B, C, and D and levels of evidence from 1 through 5. But what you'll notice on this slide, there's nothing about costs. I think Dr. Fojo's keynote lecture this morning was very informative and very powerful in pointing out the role of costs as well. There's been very little attention compared to effectiveness in paying attention to costs when it comes to making treatment decisions. There is increasing pressure worldwide. In the United States, we are obviously dealing with the implementation of the Affordable Care Act, which Terry Day mentioned in his presidential address as well this morning. Cost effectiveness is a word that is used frequently. What does cost effectiveness mean? If we look at how we actually use this word, most of the time when we say cost effective, it's just a substitute for the word inexpensive. We say cost effective, we mean inexpensive. Or sometimes people say, is it just effective at an affordable cost? But that's not really the meaning of cost effectiveness. For the purposes of the discussion today, I just want to briefly define what cost effectiveness is. Cost effectiveness is actually a ratio. It's the amount of dollars that it takes to buy a unit of effectiveness. And that's a sense of value that it provides. And the value is what we want to focus on today. Whose costs are we talking about? Well, it can be anybody. It can be the patient's costs, it can be the physician's costs, it could be the insurer's costs, it could be the hospital costs. What we want to also try and do as we think about the various perspectives that people take is to consider society's costs. So that would include everybody's costs, because it may cost something for me, but it may hurt my patient very much, or it may cost the patient a lot, but not cost me very much. We want to think about the society as a whole. Effectiveness, as I've mentioned, comes naturally to clinicians. Sometimes it's easy to think about effectiveness in terms of years of life saved from a particular cancer intervention. But sometimes it can be hard. It's harder to measure quality of life, to measure function, to measure this notion of utility, which health economists, those among you, understand very well as an overall measure of how valuable something is. And sometimes we combine these. Sometimes we combine years of life saved with quality of life to create this quality. A quality is a quality adjusted life year, and you may hear that term as well today. That tries to measure the number of life years that are saved by accounting for how good those quality of life is in those years. This is a very basic diagram that we may see again today. In this, I do have a laser. In this axis, we plot costs of every intervention and then the effectiveness. More effective treatments are to the right, less effective treatments are to the left. High-cost procedures are up here, low-cost procedures are here. If something costs a lot and it's not effective, we don't need to spend a lot of time on that. That's clearly a no. If, on the other hand, something is very effective and it's low cost, well, that's pretty good. We probably don't need to spend much time on that as well. What we really need to focus on is this. When something is much more effective or even a little effective but costs much more money or a little bit of money, is that worth it? Similarly, if we can save money but something becomes less effective, what is the adequate ratio at which we need to take a stand? What we're getting at again is this notion of value. Value is often not considered in our decisions because decisions, and that's important, because decisions that are based solely on effectiveness or solely on cost may be short-sighted. So today, we want to focus on surgical innovations. All of you know, many of you otolaryngologists know that functional endoscopic sinus surgery was introduced without a lot of debate. It caught on very quickly. The question has always been raised, was there proper assessment of the marginal effectiveness that it brought? In marginal, I don't mean a little. I mean it in economic terms. In other words, what was the marginal cost of this? Because if we don't pay attention to this, our colleagues will. Our competing specialists are always aware of this, particularly in other non-surgical fields. So the order of the debate today, we'll start with Dr. Terrace. He will argue to the value of new technology. Dr. Schuler will point out some of the drawbacks of the new technology. Then we'll have a more focused discussion on TORS. Dr. Weinstein will present the position proposing value of TORS, and Dr. Leemans will point out some of the drawbacks of TORS. And finally, we'll end with my co-moderator, Dr. Beasley, who will introduce the ideal framework as a way to think about these arguments and to present some case presentations. Before I hand it over to Dr. Terrace, I just want all of you to know that we have intentionally asked them to be provocative. We want them to make this a debate that's going to be memorable. And so we've asked each of them to push their points as much as they can with words only. We've banned the weapons. But understand that this is for the purposes of a debate, and I hope you'll find it enlightening. Thank you all. Dr. Terrace?